Hello and welcome everyone to another episode of the Menopause Symposium. Vikram, how are you today?
I'm good. I'm good. Thank you, Basil. Hope you're well.
I am well, I'm well. We received quite a few comments about the use of bisphosphonate in the menopause. And while we know that they have a place in using them if you can't use this HRT, and there is evidence of osteopenia or osteoporosis, I came across a very interesting meta-analysis by Ardebili et al. And what they did is they looked into studies that are given bisphosphonate almost prophylactically, as in like when there wasn't evidence of bone health reduction in women with early menopause. So I found the concept really interesting, and I wonder what are your thoughts in terms of this clinical practice?
Yes, interesting. Actually, it's very nice you've chosen this paper because it kind of introduces a new concept which we don't at the moment follow in clinical practice. So right now, for example, we know that if somebody has early menopause or premature menopause, so below 45, we recommend HRT as the best first line treatment until they get to 50. That's going to protect them from osteopenia, osteoporosis, and they don't have many downsides to it. They don't have risk of cancers that would apply to women after 50. But after 50, having seen various medications over the past many decades, again, the most guidelines now say HRT still would be the first line treatment or prevention medication for osteopenia, osteoporosis, especially if they have menopausal symptoms. So the kind of bar got shifted to 60 in the recent guidelines. And that beyond that, really, the first line is considered as bisphosphonates. Now, some rheumatologists, some physicians may not agree, and they might say after 50, bisphosphonate should be first line and HRT should be second. That debate continues. But generally, most of us in the menopause field, we say until 60, your best bet is HRT. But this particular paper is interesting because although it says early menopause, remember this is not early menopause they're looking at. They're actually looking at women who had menopause after 45, but they're looking in that early phase. So
Yeah.
perimenopause and soon early postmenopause who had a natural menopause. And what if you give somebody bisphosphonate then, which is not a standard practice unless they already have osteoporosis, but these are women with normal bone mass. So it'll be interesting to see what results they got and what they say.
I was actually surprised that they found 12 RCTs to include in such a quite a well-defined PICO question.
True.
So as we discussed in this exercise, they had 12 randomized trials that met their inclusion criteria. They were reported in 14 articles, and in total, they pulled data on 1,722 women. They used fairly straightforward pooling sort of methodology using a random effect we use in RevMan. They did not conduct any sort of advanced meta-analysis techniques like a meta-regression to look into the potential effect of covariates and confounders, as we always discuss in such treatment, particularly when the effect is there's long-term lag before you see a benefit. Several factors play a key role in affecting the outcome, like a woman's exercise or BMI or diet and all these other elements. So I think perhaps an IPD meta-analysis will be the next place to go from here so that we can explore the potential effect of effect modifier. They did use the Cochrane risk of bias tool to look into the quality of these studies, and overall, the quality was medium. There were some concerns about the outcome reporting risk of bias, and there was some evidence of some publication bias. But overall, it was a good quality meta-analysis. Now, when they looked into the changes in the BMD at 12 months mark, obviously, as we can see, across all of the lumbar spine, femoral neck, and total hip, BMD levels, they're all increased with the use of these bisphosphonate. And I forgot to mention that the across these 12 studies, each study used different formats of bisphosphonates. So whether it's a lead renate or a result renate or other formats across other doses, which again the authors were not able to adjust for in the meta-analysis, because obviously that will truncate the data in very small categories and defies the ability to pool data across all these studies. And when looking into bone metabolites like NTX and ALP, they also saw an improvement with the use of bisphosphonate and showing that there is higher bone formation and fixing of our generation of new bone, which is reassuring. Um, an interesting finding is that not all, only 3 studies reported on the incidence of fractures, which is really important, I think, in this case, and particularly, it could be sometimes misreported, and a few reported on common side effects with the use of bisphosphonate. And I think we all know that they're not always very well tolerated, although I think the newer formats are becoming nicer and easier to take. Particularly, I think the IV formats are becoming more popular. So there was some evidence of flatulence and odynophagia, back pain, bronchitis, and myalgia. I think that to name a few. So overall, a reassuring meta-analysis is showing that there is some benefit of bisphosphonate within its use prophylactically. But I wonder what are your thoughts in terms of, are we going to use it in clinical practice? Is this something that we're going to be prescribing commonly as menopause specialists?
Unlikely. I mean, this is basically a stimulation of thought. It's a very nice study because what it mentions is these markers start changing. The bone density starts dropping. The bone turnover markers change up to 2 years before the LMP, before the last menstrual period. Then they peak around, say, 1.5, 2 years after the last menstrual period, and then they slightly drop, but still the bone resorption is continuing for years after the menopause. So there's so much of a window where you can do something. I think the authors make a point that sometimes we wait until osteoporosis happens and a fracture happens, by which time these women have lost 25, 30% of their bone, and then we
Mhm.
are offering bisphosphonate or HRT. It may be too late. So if somebody is proactive and wants to prevent osteopenia, osteoporosis actively, the concept they're introducing is, can they have a few doses of some bisphosphonates to keep their bone mass strong? Now, I guess it's difficult in current scenario to give bisphosphonates, consider it for somebody purely for preventive reasons when they don't have any osteopenia, osteoporosis. But it's a good thought process. I think such thought processes are required for us to kind of look at the evidence and say, what can we do? Vitamin D, calcium, weight bearing exercise, that's good as the first lifestyle intervention. Can we consider proactively bisphosphonates as a preventive medication? Is HRT far better, especially for women under 50 when risks are low, or is HRT second line? So, a lot of sort of thoughts, a lot of things you can think about this particular paper. The other bit in that particular paper was that, again, I think you alluded to that, is that some of those trials are industry funded. So we don't have a lot of neutral trials.
Mhm.
And that kind of preparations they used were different. You had the risodronate, the alendronate. And again, you wonder what each of those medications will do in terms of benefits and risk. We can't use bisphosphonates sometimes more than 5 years because they can cause osteonecrosis of jaw, they can cause femoral
Exactly.
fractures, they remain in the bone for a long time. They have a long half life, sometimes up to 10, 12 years. And sometimes some international guidelines have expressed concern using them too early on in life and say HRT might be better until 60, 65, then the bisphosphonates can be started if required. So many factors to consider, I think, much more than what a short video can look at. But very interesting findings to say that it could be a concept in future where such small regular doses of bisphosphonates could be considered, especially in women at risk with risk factors.
Indeed, very thought-provoking, and thank you, Vikram, for sort of breaking it down in such details. I guess we'll wait to see what future studies will show us, and we'll keep bringing these up-to-date knowledge to our viewers. Thank you, Vikram, for joining us today, and thank you all for watching this episode. And we look forward to receiving your comments. And please don't forget to subscribe to the channel, and we'll see you in a future episode.
Thank you, Basil. Thank you.